presentation is Saumitra Rawat, anastomotic leaks, colonic anastomotic leaks.
So I think that, if I can say in a sarcastic way, that is the icing on the cake, because that's what we've been discussing. I think two anastomosis which everybody is worried about. One is the esophageal anastomosis and other is the colonic anastomosis. So I think that's an important topic. Dr. Rawat, please. And I would request Dr. Obla to please keep noting down the points which maybe you would like to reiterate and re-stress. I think people really are having problems with connectivity, because it seems Dr. Rawat has also got disconnected.
Sure, sir.
We'll wait. But we can continue the discussion what we were having.
I think one important
please.
One important thing is that whether to do a 2-stage or 3-stage or 1-stage and diverting stoma after LAR, it is an individual approach, sir. If the patient is high risk, then yes, a diverting stoma is necessary, and if patient is high risk, then a 2-stage or 3-stage procedure is on the card. So we cannot take a conclusion in a single line that this need to be done, but it is important to see on patient to patient basis what is the condition of the patient, what is the disease like, and what was the intraoperative findings, how the surgery went well, how the stapler fired, and then we should take a decision to make a stoma whether after LAR or after pouch surgery.
Yeah, and to that I would add what Diksha said: surgeons' expertise and experience.
Yes, sir.
And the patient's perception, the patient's acceptance of a complication. See, when we talk to the patients, we know that this is a patient who's prepared for a complication and he won't react in a negative way. On the other hand, there are some patients who want things to go absolutely smoothly. So I suppose wherever there is a higher chance or risk of complication, patient's psyche assessment and keeping that in mind is also very important. Of course, these days, medico-legal issues. So whatever we do, whether we do single stage or 3-stage, all this counseling, all this information has to be documented, and a good detailed informed consent is very, very important.
Yes, sir, absolutely.
Yeah, it's very true. I think it should be more emphasized. A shared decision making is crucial.
Sir,
yeah, Dash?
Sir, can we say that in ulcerative colitis, you shouldn't do a single stage procedure? And on the flip side, can we say that in polyposis coli, you shouldn't do a 3-stage procedure?
Yeah, it is understood. I think that's been what, that the conclusion of our discussion has been. 3-stage, there is no role at all in FAP. And for ulcerative colitis, 2-stage is the standard. I think that this should be the message in a masterclass.
So maybe we can continue the discussion, because it seems everyone in Delhi, Das is connected, but Dr. Diksha is also not connected, and I think Dr. Rawat has got disconnected.
So in Delhi, the thunderstorm is always patchy. Now it has gone from here. I am now in a clean environment, and I think it is raining there.
Yeah.
So it's raining. So I'm connected, but my video is off. It's raining.
So we can continue this discussion, and Dr. Naganath, maybe you can make some comments while we are waiting for Dr. Rawat to come back.
Yes, sir. Actually, our preferred method in pouch is we always do a ileostomy. That too, we do a turnbull's ileostomy, not a simple loop ileostomy, and we close it after 3 months. Because in public hospital, we have our own problems. We can't do the investigations as and when we require. If you are going to avoid the stoma, then you have to have all facilities to pick up the leak at the earliest and tackle them. So our preferred method is always to do a diverting stoma, the 2 turnbulls.
Thank you very much. Thank you, sir, for inviting me. It's such a great and healthy discussion. This is where we learn. Otherwise, we would have stuck to single stage and 2-stage. Although no one of us is doing single stage at the moment. I bring warm greeting from Sir Gangaram Hospital. This is my other affiliation, Christie's, where I am a program director of international training program, and other affiliation is Royal College of Surgeons of England, where I am a member court of examiner and laparoscopic trainer. So we all know, I think Vaibhav has made my presentation very easy. He has discussed majority of the point. I'm just going to reiterate, and I will make it faster when I see Vaibhav has already discussed. Colorectal anastomotic leak is a surgeon's nightmare. Any of the surgeons who are doing a colorectal surgery, anastomosis is the one which causes all the problems, because the patient mortality increases, morbidity increases, patient will require a reoperation, and patient relatives, especially when you are working in a private sector, they will be paying more and they will be asking too many questions, and it's difficult to make them understand that anastomotic leak, it will happen as long as it's happening in a kind of international things, and patient may need a permanent stoma. We all know if somebody had an anastomotic leak, they will have a worse oncological outcome. And the more important that is the implication for surgeon, whether they are using the poor technique or is the poor judgment, as we were discussing now, that if you are doing an anastomosis on patient whose nutrition is poor, whose hemoglobin is low, and who is on steroid, this is like a poor judgment. And then, like when I was in UK, all the surgeons are audited. Every year, you will have your mortality results, and you will have a anastomotic leak results. And if any surgeon whose mortality is higher than the national figure, then you need to go for retraining. One of my colleague whose rate was high, he went for a retraining for 6 months. So implication for the surgeons are immense. So obviously in UK, what it used to happen, they will give you a 3 figures. What's your anastomotic leak rate? What is the leak rate of other colleagues of yours in the same hospital? And third is a national figure. As long as your anastomotic leak rates are less than the national figure, that's what the aim is. And as you get trained more, your leak rate goes down. So this is the outline which I'm going to give. What is the definition of anastomotic leak? How to prevent it preoperatively, perioperatively, and postoperatively. And if you have a leak, how do you manage it? These are number of definition which has cropped up in last 40-50 years. So as you could see, that there is no specific one definition of anastomotic leak. This is the one which is normally people are using: leak of luminal content from surgical joint between the hollow viscera. And this could emerge through the wound, through the drain site, or collect near the anastomosis, causing patient signs and symptoms. And the leak, in the absence of clinical symptom and sign, is recorded as subclinical leak. So this is again classification A, B, C. A is subclinical, B is minor, and C is a major leak where the patient have a peritonitis, sepsis, and if you don't take care of it early, then the multi-organ failure. This is a slide, anastomosis is like a marriage that, you need to have a good home cooked meal. That means patient nutrition has to be good. there has to be a good blood between the husband and wife. So there has to be a good blood between the two bowels you join. There should not be any tension in the marriage. If there is a tension, you need to release it. So if your colon is not going down, you need to fully mobilize your splenic flexure so that at the anastomotic side there is no tension. Like in marriage, you need to have a circle of trust. That the same thing in colocolic or colorectal anastomosis, that you should have a complete donut. And like in a good marriage, family issue stays in the family. And the same thing is colorectal anastomosis, that you do the leak test and there is no air leak. Leak rates are variable, and I will show you. I think this is one of the largest study done in Netherlands, where they had roughly about 17,000 colon anastomosis and 7,000 rectal anastomosis. So for the colonic, their anastomotic leak rate is around 7%, and rectal anastomosis is somewhere between 8 to 11%. So all the surgeon needs to know anastomotic leak is going to happen. But the most important thing is identifying it early and treating and managing the patient early. So how to diagnose? Clinical grade C, straightforward. Patient will be symptomatic. You'll get a CT scan and there will be fluid. Near the anastomosis, there will be gas as well. Similar thing is in the clinical grade B. In subclinical, that's where the thing is patient is clinically well and you do the test like some of the surgeons, they do it routinely and then you find the leak. There are some biomarkers. CRP is used by some of the surgeons in the Western world. They are using TNF alpha, IL-6 and MMP9, done in very, very few centers. As you could see, there is a study about the CRP level, and they say the cutoff level, if CRP is more than 135 on day 4, you will most likely, or there is a higher risk of a leak. You should go and check whether your anastomosis is patent or not. So why do the leak occurs? There is a patient factors, surgeon or perioperative factors and postoperative factors. I won't go too much in detail. I think Weber has mentioned all these factors. Distance from the anal verge, male is more riskier. If the patient is obese, diabetic, or on steroid, immunosuppression, NSAID, or had a previous radiotherapy, or is alcoholic, malnutrition, chronic smoker, they all have a higher risk. And I think I'm not going to talk about the stoma. Weber has clearly mentioned that stoma leak rate is slightly less, but is safer if the patient had a radiotherapy or you are doing a multivisceral surgery, which also involves bladder hysterectomy, or if there is a presentation of fistula in the past. So these are the perioperative factor. Whether you are doing a stapling or hand-sewn, there is absolutely no difference. If you are putting a drain, it shows that there is a slight increased risk of leak if you are leaving a drain for long. Duration of surgery, intraoperative adverse event, intraoperative bleeding or blood transfusion, they all increase the anastomotic leak. If you are doing surgery on an emergency situation, if the patient has got an obstruction on bleeding, then also there is a higher risk, and multivisceral surgery, as I mentioned before. Preoperative bowel prep has not shown any difference whether there is a higher risk of anastomotic leak in colon. In rectum also, if you are, I normally don't give a bowel prep if I'm not going to make a stoma, but I will give a bowel prep if I have even slight inclination that if I am making a covering ileostomy, because I don't want to have a stool between my ileostomy and where I'm doing a anastomosis. Not testing for ear leak increases your chances of anastomotic leak, which I will show you here. Once you have checked it, and if it is airtight, chances of leak is 4%. If it is a air leak and you do it, you close the air leak at the time of surgery, it's 5%, and it is untested. The chances of anastomotic leak in one of the studies have shown to be 21%. What are the operative factors? Multiple staple for transection. If you use more than 2 stapler in the rectum, there is a high risk of anastomotic leak. If I am operating in an obese patient and if the rectum is thick, I would rather like to give a phenestrine incision and put a stapler so that I can staple it in 1 or 2 stapler at the most. I avoid going more than 2 stapler. Pouch or no pouch, or whether you are doing a end to end or side to end anastomosis, it doesn't make any difference. Both of them has got similar outcome. This is the rectal transection. These are a couple of studies. Higher anastomotic leak rate with multiple firing. If it is more than 2, there is definitely a lot of studies which shows that there is a higher risk of anastomotic leak. This is again, if you are using a ICG technique, putting a ICG in the proximal transection and after the transection, and they have done a pillar 2 studies where in 11 of their patients they changed the plan. 9 of them they did a proximal transection slightly more proximally, and in one of them they had to redo the coloanal anastomosis, and their leak rate was pretty good, 1.4%, and no leak in the above 11 patient where they changed their plan. This is the another one, SPY Elite system, which was used in couple of center in UK. This is only for extracorporeal anastomosis. And this is a paper from Oxford by Neil Mortensen group. This was a very early paper which showed that, if you got a good perfusion, your leak rate are nearly 0 or 1%. Post-operatively rectal tube, there has been some studies that especially in cases of anterior resection or low anterior resection or ultra low anterior resection, if you put a rectal tube or if you put a catheter, as you could see that they have done a study on randomized control study on 398 patient. Overall leak rate was 6.8%. Where they put the tube, it was 4%, and no tube was 9.6%. These are the other things which some of the surgeons have used, using a fibrin sealant or nitinol compression rings. This is about the reinforcement Gore SIM guard. This is similar to when bariatric surgery was done. They were using a seam guard on the stapler, both on the anvil and on the circular stapler on both the sides, anvil and end of the stapling shaft, putting a Gore SIM guard. And in this particular one, they found no significant difference whether you are using a reinforcement or not using the reinforcement. Now I am coming to the management of the anastomotic leak. again is subclinical, minor or major. So if it is a subclinical leak, you can put a drain through the anastomosis, or you can put a fibrin glue. In a Western world and some of the center in India, they are using a endovac as well, with good results. And this is about the minor leak. This usually happens, if patient is having a prolonged ileus, having a recurrent fever, pelvic pain, or sometimes, if you delay it further, then you are having a discharge from the vagina and rectum. So this is what happens if you got a tiny or contained leak. You can do a CT guided drainage. If there is no abscess or collection, you give a antibiotic and rescan. If it is a large leak, then you need to take the patient back to theater. If patient doesn't have a covering ileostomy, give a loop ileostomy, drain all the collection, depending on how much your circumference is involved. What I normally have it in my practices, if it is less than 1/4 of the circumference, I just leave it. If it is a total disruption, then it's a double barrel stoma you need to give, or you can, if the contamination is high. This is about the major leak. Sudden onset of patient will have generalized symptoms of tachycardia, tachypneic, and hypotension, fever, and patient is having a peritonism as well. Again, the blue shows whether the complete disruption is present or not. If there is a complete disruption in intraperitoneal, the safest thing is double barrel stoma, and you resect the anastomosis. If it is extraperitoneal, then you can do the end ileostomy, or if it is not a complete disruption, then you go lavage the whole thing and put a drain in and do the covering ileostomy. I will just present one of the patient. This is a video quite old. Had a LAR, 2 firing of stapler, found to have there was a leak, found to have a anterolateral dehiscence which was less than 25%, and so defect was not closed, gave a covering stoma, pelvic lavage, and leave a drain there. So this is when we put a laparoscope in, you could see there is a collection there in the pelvis. I will just take it slightly further. It's just a 2-3 minutes video, just trying to separate the small bowel which is there so as to look into the pelvis and looking into where the collection is, trying to push the bladder slightly higher up. That is where the leak was seen. It is anterolateral leak, less than 25% of the anastomosis. So first important thing is control the sepsis. So take out everything, give it a good wash. And once identified that there is not a full dehiscence there and it's just the anterolateral, check the posterior also and the anterior, and then leave the drain there. So this is some of the non-traditional. That particular patient had a covering ileostomy, and then we reversed the ileostomy after 6 months, not after 6 weeks. These are some of the non-traditional technique. Endovac is one of them, and this is where you put the endovac in the cavity, and normally you leave it for 3 to 4 weeks. It depends on when everything settles down, and it is best if it is applied early. If the anastomotic leak you can catch early, and you put a suction drain there, and there is a 95% success rate. Another technique is putting a temporary stent, but not many people are using it. because there has been few studies that, it's not working well. Some of the gastroenterologists, they are putting in an endoclip or beer claw where the anastomotic defect is. I think these are some of the myth of the anastomotic leak, that all leak needs a operation. They don't. And all leak with the reoperation require dismantling of anastomosis and giving is permanent stoma. And this is again a myth that there is no role for laparoscopy. And another myth is on day one, it can't be leak. And another myth is their bowel is working, so it can't be leaked. These are the myths which we should not go for. I think the most important thing is, as Vaibhav has already mentioned, that we need to optimize the patient preoperatively, and the surgical operator need to see exactly what is needed out of the patient. And the quality assurance is very important, that you need to do the audit. This is our audit which we presented in SAGES. These are the surgery which was done by my juniors who were clinical assistant or final year PGs, just to make sure that their results are similar to what I am or better than mine. And this is a fellowship which we started in colorectal surgery with the Christie's Hospital. In summary, leak are bad. I think the most important thing is prevent the leak, optimize your patient, optimize your surgical technique, discuss with your colleague. And I must say that this is a great forum where all of us are sharing our point. And I think, as other colleague has said, that give a stoma to the high risk. And what I always believe in, if the patient is not recovering the way you like to, I think you need to investigate the patient sooner. If patient is having a ileus or patient is slightly tachycardia, because diagnose your leak early and manage your leak early. This is the most important thing. It's a teamwork. That's the team from Gangaram. And Dr. Kapoor, thank you very much for inviting me. The greatest accomplishment of man has resulted from transmission of idea and enthusiasm. And your Jaipur forum is great, and so is AIG, where we share our ideas, and we all are enthusiastic about teaching and training. Thank you very much again for inviting.
Thank you, Dr. Rawat, for your kind words, and we will be very happy to have you again and again in these online sessions. Over to you, Dr. Sastry and Dr. Das, for the discussion. We can have a discussion on the Dr. Rawat's presentation, and then we can have open house session where Dr. Nagnath maybe can start the discussion.
It's a wonderful presentation, Dr. Rawat. You very clearly laid down the guidelines and what is new. The vascularity, I just have one question. Although you referred to the how important is vascularity, the ICG, which was mentioned in the earlier presentation, and Vaibhav was saying you use in all the patients. Whereas yesterday there was a presentation and where the evidence was shown to be not too much in favor of ICG. What is your take on ICG, which is the in thing these days in GSSG?
What we are doing, sir, is two of my previous PGs. What we are doing is we are doing a thermographic, this like a mobile phone. And what we do is look for the temperature. So I think it is working well for us. Since that our DNB student are doing, we look at the change because it detect whether there is a vascularity at the edges where you are doing a anastomosis. See, it is individual whether it's working or not. I am not using ICG much, But this one, which this is where we are using, it has been accepted for publication in one of the journal, and I think this is a device which has been made by one of my friend who is based in America. He was from Maulana Azad. He was a professor in Philadelphia, and then he did his MBA from Wharton. So this is what he has come out with, and we are finding it very useful. We are finding it useful in, I would say, one third of the patients. We are, uh, you know, uh, making changes in where our anastomotic line is to be. We are making changes, sir. Eventually, it all depends on what is working best in individual hand. That is what I always believe in. If somebody is doing it the way they are doing it, as long as leak rate is less than, say, I would say 5%, that is what it is, sir.
But Dr. Shastri, my comment on ICG debate or controversy which you asked is that it's something which will do no harm. It's simple. I don't think it's very expensive, although I have not used it myself. But if it shows that there is a problem with the vascularity, you then and there you have an opportunity to take some measures to revise it, refashion it, as opposed to handling a leak later. So I see no reason, even if the evidence is not there, that if you can use it, you should probably use it.
Sir, one thing,
Yes.
you mentioned this, it's not a costly drug. Drug is not costly, but the equipment, the laparoscopic tower with ICG facility, if someone doesn't have from the beginning, they need to procure it. So that is a costly affair. One thing. Second is because we are doing in our institute, it is kind of a problem solving tool. If you can see the vascularity is good because you are experienced for last 30 years, you are seeing the bowel whether it is devascularized or not. But in some cases, when you are dicey, whether it is actually vascularity is there or not, then in those cases, yes, it sometimes helps you out yet that the end of the where you're going to the anastomosis is well perfused or not. Similarly, in colonic interposition, when we are doing in when the colon is reached to the neck and we find that mucosa is slightly not good or the it is not in those cases, yes, ICG is beneficial that you can after doing the anastomosis, you know that it is well vascularized, perfusion is good, and then you can sleep, take a good sleep at the night. There's nothing going to happen. So I think in that way is useful, sir.
I think our results, they are not, I would say that it has shown a lot of changes in the anastomotic leak in a control and after we have done it. Uh, there is a, I would say the changes is about, I would say the patients is it's in a single digit. But then also, I think you sleep better. That's what I would say. That, if I've done an intraoperative infrared thermography, and it is a very simple tool, it's on the mobile, you just put it on the bowel. And obviously, if you are doing a colorectal anastomosis, because we do it laparoscopically, we can't put it inside the tummy, but the proximal part of the bowel, that is the most important thing. And what I have also done previously, when I started, I was taking IMA just at the origin. What I have also started doing is this: I try to preserve the left colic if possible. That is what it has helped me, because I would say that we haven't had any mortality in colorectal cancer. We would have, I think, 3 4 leaks in last many years. Weber has worked with us for 1.5 years. He was in Gangara, and I think the thing is, do what works for you. What works for you. I think a lot of my uh, uh, clinical assistant and registrars, they say, sir, why you are leaving left colic? I said it works with me, because if the left colic is there, and if I don't find any macroscopically, with my eyes, there is no node at the origin of IMA, because for initial 6 7 years of mine, I have divided IMA absolutely at the origin. I will just leave 1 centimeter of the cuff on the aorta, and then I think with time I'm leaving left colic, and I think in last 4 5 years, we didn't see any sort of leak or anything. Right colon, yeah, we had one or two leaks in last 1 to 2 years, but then I think what works best for particular person, if it is working well, I won't change.